So back with the H&H or the hemoglobin or hematocrit, make sure you're looking at the normal ranges for male and females. We may see the hemoglobin and hematocrit decreased just with age, called anemia of chronic disease or anemia of aging, or we may see this in patients that have had significant blood loss from a trauma or a surgery, or we might see it from a poor diet. Okay. Then in chapter 6, we talked about the cholesterol levels of HDL, LDL, and triglycerides. And when we talked about renal diets, we talked about potassium. And this is an important indicator for those folks that are on a renal diet, and we want to make sure that we're measuring this. As you know, there's a lot of foods that are high in potassium that are recommended that people eat, but if they have renal issues, they might be put on a low potassium diet. Because that's so restrictive, we want to make sure that they actually need that low potassium diet. So measuring their serum potassium is helpful in not being too restrictive. Then we have the lab called the blood urea nitrogen, or the BUN, you'll hear it reported as. This is an indicator of kidney function as well. So if someone has an elevated BUN and they are not on dialysis, this might be an indicator where you would utilize that protein needs lower than the RDA. So remember, if they have chronic kidney failure, end-stage renal disease, they are not on dialysis, then they'll need 0.6 grams of protein per kilogram of body weight, versus those who have end-stage renal disease are on dialysis, then they have much higher protein needs. Recall that's about 1.5 grams per kilogram of body weight. Next, we move on to clinical information, diagnoses. There's several diagnoses that are going to put someone at nutritional risk immediately, like newly diagnosed type 1 diabetes, HIV/AIDS, pressure ulcers, advanced metastatic cancer. Obviously, their skin status, like we talked about with someone with pressure sores. Physical symptoms or conditions, nausea, vomiting, that's untreatable. There's certain medicines that have some food-drug interactions, and actually have some homework for this week that talks about some of those medications, and we'll review that more in depth coming up here. Medical and social factors, okay? What's their teeth? Do they have nice fitting dentures, or are they missing some teeth? Do they have, are they living in a rooming house and they don't have access to a kitchen? Do they have transportation issues to get their groceries? Do they have limited skills for preparing foods? Do they suffer from rheumatoid arthritis and have some problems with hand function and are unable to complete basic nutrition tasks in the kitchen? And then are they being fed via tube or into the GI tract or into the vein? And that's information that we'll want to use to formulate a nutrition assessment. The next few slides talk about some of the medications that we'll see have a great impact on someone's nutritional status. And so when we see clients that are on these medications, we're going to want to make sure that they are aware of the interactions that can either affect the drug metabolism or some of the side effects that they might have that are related nutritionally. Stop taking pictures of me. My daughter's taking snaps and trying to put me on her snap. Sorry. Anyway, here we are back to the lecture. So grapefruit juice. Many long-term care facilities and hospitals no longer have grapefruit or grapefruit juice on their menu because of the interactions with many drugs. So simvastatin, which is a common statin drug prescribed to lower cholesterol, that interacts with grapefruit juice. And what happens is it increases the effectiveness of the drug. So we'll also see that with some hypertension medications as well. Vitamin K rich foods like Swiss chard, kale, Brussels sprouts, cranberries, they have an effect on a blood thinning medication called warfarin, or it's also known as Coumadin. So basically, this blood thinning medication is